Hi, thank you for joining us for the ASHNR 2020 virtual session on nodal imaging, unknown primary tumor, and mimics. I'm Mari Hagiwara. I'm from NYU Langone Health in New York City, and I will be one of your moderators for this session. My co-moderator, who you'll be seeing later, is Edward Quigley from the University of Utah in Salt Lake City. Our first lecture will be given by Peter Song. He is a professor of radiology, otolaryngology, and radiation oncology, and the chief of the head and neck imaging section at the Ika Han School of Medicine at Mount Sinai in New York City. He'll be speaking on classified and unclassified lymph nodes of the head and neck.
This is Dr. Song, and I want to thank the program committee for asking me to give this talk. I have no conflicts of interest. And we're really going to be talking about nomenclature for the lymph nodes in the head and neck. But before we do that, I thought it would be interesting just to sort of review how those lymph nodes and lymph vessels got there. Putting things into perspective, it's been estimated that there are about 1,000 lymph nodes in the body, and over a quarter of them are in the head and neck. And when we're going to try to communicate with the clinicians taking care of the patient, we need to be able to identify for them precisely where the nodes are that we think are significant. And the only way we can really do this reliably is to try to place those nodes in some anatomic relationship to fixed anatomic structures. Now, if we review for a moment how this system all came about, as we know, there are lymphatic vessels and lymph nodes. Now, of course, we don't normally see the lymphatic vessels, but we do see most of these nodes. So in the head and neck, the lymphatics arise from the anterior cardinal vein. There are cells within the wall of the anterior cardinal vein that are going to be eventually lymphatic endothelial cells. And through a series of molecular changes, eventually these cells break out of the wall of the vein and become primitive lymphatic endothelial cells. These cells in turn eventually form a network, and eventually that network becomes the adult lymphatic vasculature. So this is a diagram of an adult lymphatic. These strands hold the walls of the lymphatic vessel to the interstitium so that they don't collapse. There are, of course, valves so that the lymph can only flow in one direction. But interestingly, there are gaps in the wall between the cells that form the wall, allowing interstitial fluid, inflammatory cells, and tumor cells to enter the lymphatics without any expenditure of energy. Now, it used to be thought that the lymph nodes developed at the end points of the lymphatic vessels, but in fact, that's not true. They develop separately. And experimentally, you can actually have animals that have lymph nodes without any lymphatic vessels. So this diagram just summarizes what's going on. And you can see that eventually you get the nidus of a developing lymph node, and as it progresses, it starts to attract the lymphatic endothelial cells, which eventually attach to it and become the afferent and efferent lymphatics. So we now have the connection between the lymphatic vessels and the lymph node. So if we know where the veins are, then we know where the lymphatics are. And we know that all the lymph flow is down into the lower neck. Now, initially, when they tried to classify things, the surgeons did it when the patient was opened at the table, and they found a lymph node and they placed it, say, in the submandibular triangle. But we now know that many patients today are not being initially treated with surgery. Rather, they're being treated with radiation and chemotherapy. And so we needed to come up with an imaging-based classification system because virtually every patient with cancer is going to have a pre-treatment and follow-up scans. So how did this all develop? Well, before there was imaging, the clinicians had palpation and they knew that they could identify certain structures in the neck. And if lymph nodes were found, say in the submandibular triangle, they were called the submandibular nodes. So initially, all of the nodes had anatomic terminology. The important internal jugular chain was just called the internal jugular chain of nodes. We had nodes following the spinal accessory nerve, and connected in the internal jugular and spinal accessory groups is the supraclavicular group. We also have visceral nodes. Well, it became a question in the literature, which of the nodes in this area was most important in terms of prognosis. And it turned out that really it wasn't a node particularly, but any node in this region. And this region became known as a level. So for instance, the submental nodes became 1A, the submandibular 1B. The important internal jugular chain was divided into 2, 3, and 4 levels, the spinal accessory 5, and the visceral node 6. But note that they still have nodal groups that have their anatomic terminology, and that includes the retropharyngeal nodes. So here is the imaging-based system. Between the anterior bellies of the digastric, it's 1A. Submandibular triangle, but not behind the submandibular gland, 1B. Skull base to bottom of hyoid, 2. Bottom of hyoid, bottom of cricoid, 3. Bottom of cricoid to top of manubrium, 4. Anything behind the sternocleidomastoid is 5. We'll come back to 2A and B in a moment. So again, here's the submental, the submandibular, the very important internal jugular chain, the spinal accessory, a level 5, the supraclavicular, and finally the visceral nodes. Now, mentioning those visceral nodes, we know that they encompass the thyroid, larynx, and trachea, but they're only defined as level 7 nodes, which are the nodes below the top of the manubrium, when they're above the innominate vessels. If they're below the innominate vessels, then they're superior mediastinal nodes. A word about the retropharyngeal nodes. They're the primary drainage of the oral cavity and oropharynx when we're born. It is believed that because we have so many inflammations and infections when we're growing up, that the afferents to them become obstructed, and therefore the primary drainage in adults to the level 2A nodes, and from there occasionally to the retropharyngeal nodes. How do we have evidence that this is probably correct? Well, if you have a tonsillar abscess in a young child, you're likely to find an abscess retropharyngeal node. If you find that same abscess in an adult, you're unlikely to find a retropharyngeal node. We look for them just lateral to the pharynx and medial to the carotid sheath in the nasopharynx and oropharynx. So here we have a young child with a normal inflammatory retropharyngeal node medial to the carotid artery. Here we have a patient with a metastatic retropharyngeal node medial to the internal carotid artery. Here's a more complex case. The artery's in here somewhere. This is a retropharyngeal node, and if they're lateral and posterior, they're going to be level 2 nodes. So let's get into that. Looking at this case, between the anterior bellies of the digastric 1A, in the submandibular triangle, but in front of the back of the submandibular gland, 1B. If you have a node in front of the sternocleidomastoid primarily, lateral to the carotid sheath, it's 2A, and if the nodes are deep to the sternocleidomastoid but not behind it, then they're 2B. Here we are below the hyoid now in level 3 territory, and these are level 5 because they're behind the back of the sternocleidomastoid. Now I want to just spend a moment talking about a few interesting nodes. if you have suboccipital nodes, it used to be a sign of German measles. But since German measles is uncommon today, we have to look for other etiologies. Now, if you have an infection and an abscess in the posterior scalp, you may find them. But I want to point out they may be the only manifestation in the head and neck of lymphoma. And that was the case here with these two suboccipital nodes. They're homogeneous, they're well delineated. Almost all the pathologic adenopathy was in the abdomen, but these were the only manifestations in the head and neck. A word about the supraclavicular nodes. Dr. Ho in Japan, who saw many cases of nasopharyngeal cancer, defined a triangle, the anterior upper and the posterior upper margins of the clavicle, and a point clinically very easy to find where the back of your neck hits your shoulder. So any node in that triangle is a supraclavicular node. But it turns out anatomically that they're all lateral to the scalene musculature and the sternocleidomastoid. So for instance, here's scalene and sternocleidomastoid. These nodes are lateral, so I find it easiest to identify them on coronal images like this. In addition, there are superficial nodes. And these nodes we don't usually pay attention to, but they are an entire network basically related to skin lesions, primarily basal and squamous cell, occasionally infections. So we have a level system for all of this, but I want to just emphasize that these nodes and the retropharyngeal nodes all retain their initial non-level anatomic terms. Now here we have a patient with a homogeneous enlarged 1A node. Again, this was the only node abnormal in the head and neck, and it was lymphoma. Here's another patient with the only homogeneous enlarged node at level 1B. You know it's not arising from the submandibular gland because the facial vein can be seen in between them. Again, the only manifestation of lymphoma in the head and neck. And finally, a buccal node. So that suboccipital, buccal, and level 1A and 1B nodes, in our experience, may be the only manifestation in the head and neck of lymphoma. So if you have an enlarged homogeneous node, at least consider it. Now here we have a patient with multiple nodes. How are we going to identify them if in fact we want to label all of them? Well, these are 1B because they're not behind the sternocleidomastoid. These are 2A, and these are all 2B. What about this? This was a young woman with a partially cystic node in the neck. You have to think about papillary thyroid, which is what it was, but to identify it, it's a 2B because it's not behind the sternocleidomastoid. This is another woman with a huge node here. It's between the pharynx and it's pushing the carotid sheath laterally. And this was a huge retropharyngeal node in a woman with papillary thyroid carcinoma. Another patient, here's a single node, but we are below the cricoid, so we're in level 4 territory. And that's what that node would be. Again, a node and a group of nodes. So here's the anterior scalene. This makes this a level 3 because we're not below the cricoid. And these are all lateral, so these are supraclavicular nodes. And then we come to another case like this, and if we were going to label these nodes, these would be 1B, these would be 2B, and this would be a 5 because it is behind the sternocleidomastoid muscle. So this diagram or drawing indicates for each level where the most likely primary tumor would be. So the purpose of this review was to emphasize using correct terminology when talking about lymph nodes. And I want to give you another clue that we found very helpful. if when you identify a node, you also put in parentheses the series and the image number, this allows the clinician to locate exactly in the study the node you're talking about. But it also helps us because we're likely going to get the patient for follow-up. And when we do, we can go back to the earlier study and identify the pathologic node that we mentioned. Thank you very much for listening.
Our next lecture will be given by Robert Morales. He's an assistant professor of radiology and otorhinolaryngology at the University of Maryland in Baltimore. His topic is nodal imaging, normal or abnormal.
Hi, this is Rob Morales from the University of Maryland, and today I'd like to review how I approach adenopathy in the neck, specifically in patients with underlying head and neck cancer. Now, this is no easy task, as there are approximately 300 lymph nodes in the neck, but the significance of adenopathy cannot be understated. A single positive lymph node in a patient with an underlying head and neck cancer reduces the survival by approximately 50% compared to an N0 neck. If there's extracapsular extension, there is a further reduction in survival by an additional approximately 50% and an increase in the incidence of distant metastasis and tumor recurrence. This is an illustration of a lymph node given to me by Dr. Sam. Here you can see the afferent lymphatic vessels along the periphery, the efferent lymphatic vessel, the cortex, the medulla, and the region of the hilum of the lymph node. Tumors that extend along the lymphatics tend to deposit along within the subcapsular sinus at the periphery of the lymph node. This is illustrated on this histologic specimen where there's tumor deposited along the periphery of the lymph node and then extending into the cortex, medulla, and resulting in bulging at the region of the hilum. And this reminds us of some of the ultrasound features of metastasis, where there's potential loss of the fatty hilum, a rounded morphology of the lymph node. You can have an increase in peripheral vascularity. The size, features such as size, necrosis, and extracapsular extension, we're going to discuss in more detail. Now, this lymph node corresponded to this right submandibular level 1 lymph node. Other than that rounded kind of full morphology, not a lot of other suspicious features on CT or MR imaging. On metabolic imaging, however, there is increased uptake, actually bilaterally, and both of these lymph nodes were positive for tumor. And the primary here was an oral cavity carcinoma. Now, we have to take all the features, many features, when we're thinking, and put them all together when we're thinking about whether there's possible metastatic adenopathy. In order to do so, you have to have a good understanding of the somewhat predictable, more typical drainage pattern of these primary sites. Now, obviously, any tumor can go anywhere it wants and involve any lymph node it wants, but there's a relatively predictable pattern. I used to find this quite confusing, but we're going to just keep it simple here in our discussion. So with oral cancer, these tumors tend to involve the lymph nodes at level 1, 2, and 3. Nasopharyngeal carcinoma, which commonly presents with adenopathy, tends to involve the retropharyngeal lymph nodes and extend along the jugular chain and can also involve level 5 lymph nodes. Oropharyngeal cancers like to involve the retropharyngeal lymph nodes and extend down the jugular chain. Laryngeal and hypopharyngeal cancers typically involve the jugular chain, and hence they involve the more inferior lymph nodes, can extend to the supraclavicular fossa involving 4 and 5B. Now, if you have an isolated level 5 lymph node, in addition to thinking about nasopharyngeal carcinoma, like we mentioned, you also want to think about skin cancers involving the scalp and neck, and also lymphoma. If you have an isolated level 2B lymph node, that is a lymph node at level 2, but posterior to the internal jugular vein and not touching it, in isolation, again, you'd like to think about skin cancers or perhaps a lesion in the underlying parotid gland. For retropharyngeal lymph nodes, we already mentioned nasopharyngeal carcinoma and oropharyngeal cancer, but also oral cavity cancer, tumors in the paranasal sinuses, also tumors that grow particularly along the posterior pharyngeal wall. Even thyroid cancer can metastasize to the retropharyngeal lymph nodes. With regard to contralateral adenopathy, there's an increase when you already have ipsilateral adenopathy, and particularly with lesions that approach the midline. You can see this with base of tongue cancers in the oropharynx. Now, the post-treatment neck is a special circumstance, and if the patient has had just radiation or neck dissection, both of these can alter the lymphatic drainage. In the case of neck dissection, a lot of the lymph nodes there have already been removed. So when you get recurrent adenopathy in these patients, they can recur at atypical locations, so you have to be particularly aware. This is a patient with recurrent oral cavity cancer here, and you may have noticed the lateral retropharyngeal lymph node, noted medial to the internal carotid artery. But in this patient, there was a kind of atypical recurrence of adenopathy down in the supraclavicular fossa. Right? So in these patients where there's already been treatment, the lymphatic drainage can be altered. Some of the lymph nodes may have been removed. So you have to be particularly aware of recurrent adenopathy in somewhat atypical locations. With regard to parotid lymph nodes, so this includes the intraparotid lymph nodes, periparotid, preauricular lymph nodes. When we see adenopathy there, we have to think about skin cancers involving the scalp or facial region. This was a patient with squamous cell carcinoma of the scalp that metastasized to the parotid gland. And in these patients, if they're planning to do a neck dissection, they would typically include parotidectomy. Also keep in mind that these lesions can also extend to and involve the occipital lymph nodes. With regard to supraclavicular adenopathy in isolation, unless it's a thyroid cancer in the neck, the primary is typically below the clavicles. So on the right side, you typically think about thoracic and breast malignancies. On the left side, you think about thoracic and breast malignancies, but also abdominal and pelvic malignancies that it can extend along the thoracic duct and deposit on the left side in the region of Virchow's node. Now, there can also be kind of variations in the drainage, and they can also go to the right, but more commonly to the left side. Here are examples of supraclavicular adenopathy in isolation. So Virchow's node here, enlarged in a patient with esophageal CA, and here with endometrial cancer. Now, I think these nodes here are easy to miss because there's so many rounded structures in the supraclavicular fossa, right, with the muscles, the vessels, and I think it's a tough area. So what I do to try and protect myself from missing nodes here, I find the internal jugular vein and the anterior scalene muscle and make sure it sits right on top of the muscle or that there's clear fat between the two, because the nodes like to, kind of wedge themselves in between the vein and the muscle. So I make sure of this to make sure I'm not missing any supraclavicular adenopathy. And of course, you have to look, more laterally as well. On these axial T2 weighted images through the cervical spine, if you pay close attention, you can often see the thoracic duct. Here it is here, as it typically extends and joins at the confluence of the internal jugular vein and subclavian vein and empties there. In this case, there's a little bit of a patulous component of the distal thoracic duct, which you can sometimes see. Now, with regard to search pattern, right, everyone probably does this differently. What I typically do is I start on the right side of the neck and go from top to bottom, concentrating on the jugular chain and spinal accessory lymph nodes, working my way down. When I get down to the bottom in the supraclavicular fossa, again, I find my internal jugular vein, my anterior scalene muscle, make sure nothing's wedging between there. In this case, there is a lymph node here, a right-sided supraclavicular node. I then evaluate the superior mediastinum, and then I go look at the left-sided supraclavicular fossa and work my way back up the left jugular chain and spinal accessory region. I then spend extra time at level 2 and look at, the region of my jugular-digastric lymph nodes, the highest level 2A lymph nodes. I just think this area is a little bit complicated with a lot of rounded structures, the submandibular glands, the vessels, the digastric muscle, and particularly if there's not a lot of fat. I find that for me, I can, some of these nodes don't stick out as much. Then I look a little more anteriorly and evaluate the submandibular region. Then I spend extra time looking at the retropharyngeal region. This is a very, very important area for us to clear, right? These lymph nodes are clinically silent in terms of they're not palpable and they usually don't produce symptoms. So we're really responsible for this area. So here you can see there is retropharyngeal adenopathy bilaterally. Now from there, I evaluate my parotid lymph nodes, occipital lymph nodes, particularly if there's underlying scalp or skin lesions. If you're curious what was going on with this patient, it was very interesting. This was a patient that came to tumor board, biopsied on the outside with a diagnosis of oropharyngeal cancer. And when we first opened up this case, I was, surprised by the extent of adenopathy. And of course it's possible, but when I first opened it, I thought maybe this is lymphoma, could it be nasopharyngeal carcinoma? But the patient had biopsy proven, was reported as oropharyngeal cancer. But the more you look at this really looks like an enlarged retropharyngeal lymph node. And I think it was biopsied through the tonsil, which was bulging on that side. So we further evaluated the images and saw that in the nasopharynx, there was asymmetry and fullness on the left in the region of the fossa Rosemuller with enhancement here. No trapped secretions in the mastoid air cells or middle ear, but still quite suspicious. And on PET, there was increased uptake in that region. The patient lived quite far away, but what we tested the biopsy lymph node, and it was Epstein-Barr virus positive, EBV positive, and this was a nasopharyngeal carcinoma. Now, I want to just go back and talk about retropharyngeal lymph nodes again, because again, this is an area that I think we're particularly responsible for because they're not palpable, often asymptomatic. I think they're also very difficult to see sometimes, right? The lateral retropharyngeal lymph nodes are the ones we more typically see that kind of wedge themselves medial to the internal carotid artery. The medial retropharyngeal lymph nodes we less commonly see. Here, there's a little bit of necrosis, maybe makes it a little bit more obvious, but often these kind of blend in with the prevertebral musculature. So I spend extra time really clearing this area. If you don't, they don't really stick out. Here you could see there's increased uptake on PET. There was tumor progression in this patient and progressive disease. And even then, it's still not that easy to see this lymph node, right? There is some necrosis here, some asymmetry. So it's visible, but I don't think it's all that obvious. Even on PET, I've seen it misinterpreted as, some muscle activity in the prevertebral musculature. So just, spend extra time evaluating retropharyngeal lymph nodes. Now, in terms of size criteria, I don't want to spend too much time debating, the best way to measure lymph nodes. I know everybody does it differently. I personally use long axis dimension. That's the way I was taught. Also in hearing, lectures by Dr. Sam, I think it is important that the clinicians can feel most of the nodes in the neck and they estimate the largest size. So it correlates better with what they're finding when we provide the longest axis. When we talk about nodal categories in the TNM categories, that's also given in longest dimensions. So that's the way I go about it. You can do it a whole host of ways. Looking at the ratio, I don't make these ratio measurements, but I do acknowledge the fact that the rounder the lymph node is, the more suspicious. And no matter what measurement criteria you use, you're probably still going to be wrong approximately 15% of the time. Now, so using long axis, I use 15 millimeters as my cutoff for top normal for level 1 and your jugular-digastric lymph node, which is your highest level 2A. Everything else, I use a 10 millimeter cutoff for, except retropharyngeal and parotid lymph nodes, which should be quite a bit smaller. So I use an 8 millimeter cutoff. Now, we still have to use common sense, right? So if you have a cluster of lymph nodes, 3 or more lymph nodes that are in the primary drainage site of a tumor, you may want to drop your size criteria down a little bit, right? And still be very suspicious. Now, a lymph node with necrosis or cystic change or extra evidence of extracapsular extension, those are pathologic no matter what size they are. So let's talk about clustered lymph nodes a little bit. So this was a patient with a left-sided palatine tonsillar cancer that's not visible here on this image, and had a very suspicious level 2A lymph node, right? It's large, it's round, there's some necrosis here, increased uptake on PET. But then there were these additional lymph nodes, level 2A, 2A, 2B, this kind of cluster of lymph nodes, again, quite small, right? Not even 1 or 2 millimeters smaller than what you'd use as top normal, but even smaller than that. But this is a tough situation, right? Because could they be just reactive lymph nodes to inflammation because of the tumor? Sure. But you still have to raise some suspicion, right? They're clustered. I don't see lymph nodes even close to their size anywhere else in the neck. On PET imaging, I don't have the SUV value, but they're a little bit hot, and hot particularly for an even small node. So, you still have to view these with suspicion. Another example of a large oral cavity cancer eroding here into the mandible. Now, this lymph node is going to be pathologic, right? It's enlarged. But what about this lymph node? It's small, but it's round. It's in the primary drainage site. Is there some early necrosis there? How about these lymph nodes? There's a level 2A, also another level 2A posterior to the internal jugular vein here, but touching it. This one measured 9 millimeters, a little bit full, a little bit more enhancing maybe than some of the other nodes. Likewise, this level 5 lymph node is rounded, not particularly large, but these are all kind of clustered along the expected, kind of lower progression of drainage. And you can always have skip areas of adenopathy, right? But again, these are tough situations. These are the SUV values, right? PET can often help. But again, you just have to be careful, and I think view some of these lymph nodes with suspicion, knowing the drainage pattern, particularly when they're clustered, when they're larger than any other lymph nodes that you see. Now, when there's necrosis or cystic change within a lymph node, that is pathologic regardless of the size. Right here's 2 necrotic lymph nodes. Another patient with recurrent laryngeal cancer with a small lymph node, but necrotic, so pathologic, progression of disease with an increase in size of that node. Here's an additional patient with recurrent laryngeal cancer and a necrotic lymph node. On PET imaging, there's increased uptake within the primary, but not within the necrotic node. And you can see this, right, that there may not be increased uptake in these cystic or necrotic nodes. And it is a pitfall, particularly if there's a non-contrast CT that was done with the PET, as in this case. So this was a case presented to tumor board of a known base of tongue cancer with increased uptake here, but the outside report on the PET was no suspicious adenopathy, right? No increased uptake on PET. We looked at this node. It wasn't particularly large at level 2A, but it was rounded. And when we did MR imaging, we saw that this was a cystic lymph node, right? So we weren't surprised there was no increased uptake. But this is a pathologic lymph node, and it's on the contralateral side, so it changed management in that now they would raise the dose for the radiation therapy than they would have planned had they followed the advice here saying that there was no adenopathy on that contralateral side. So it made a big difference in the patient's management. This was a patient with adenoid cystic carcinoma in the buccal region. On this initial inspection, this level 2A lymph node wasn't enlarged, but we were wondering, is there a little bit of necrosis here? We looked at some thinner sections, and this was actually fat within the hilum, which can be a bit of a pitfall. So this is not suspicious, right? That's fat within the hilum of the lymph node. Extracapsular extension, right? If you see surrounding the lymph node, infiltration of the surrounding fat, extension into the adjacent soft tissues, right? You can see these findings that may suggest extracapsular extension. In this patient in particular, there was even evidence of involvement of the spinal accessory nerve with some atrophy of the sternocleidomastoid muscle and the trapezius muscle. So extracapsular extension, right? That's something that you'd want to discuss in your report. And also, no matter what size the node is, right? If you see this, you're going to be very suspicious that this is a pathologic lymph node. And then when we see some of these cystic lymph nodes, they can be really cystic and just look like a cyst. However, in an adult, right, any cyst that we see in the neck is going to be cancer until proven otherwise, right? So this is an example of a patient, HPV positive after sampling of the lymph node, clinically unknown primary. The primary is eventually found in the right palatine tonsil, but you could see in these lymph nodes, they can be very, very cystic. Another example of cysts within the neck here, along the left side of the neck, one had calcification. There's also focal calcification in the thyroid gland, right? And this ended up being papillary thyroid cancer. So again, these lymph nodes can look just like simple cysts, and in an adult, this is cancer until proven otherwise. Also keep in mind, calcifications within lymph nodes of the neck does not mean that they are benign, right? You can see this with different malignancies, including thyroid cancer and rarely head and neck squamous cell carcinoma. This is a patient, post-contrast fat-saturated T1 weighted image. It looks like a solid enhancing enlarged lymph node. But on pre-contrast imaging, it's hyperintense on T1, which you can also see with thyroid cancer. These were both cases of papillary thyroid cancer. There's additional techniques that people have looked at to evaluate for metastatic adenopathy with diffusion. Lymph nodes that contain malignancy tend to have lower ADC values. People have looked at MR perfusion, texture analysis. We're doing more and more dual energy CT. In general, though, as a practical point of view, when there is suspicion of a potentially malignant lymph node, maybe not meeting specific criteria, but we're still suspicious, really these patients tend to all go to ultrasound for FNA and to evaluate whether there truly is tumor involvement, particularly if it's going to change management of the patient. Thank you very much for your attention, and I hope you enjoy the rest of the conference.
Hello, and I'd like to welcome you to Session 12. I'll be continuing our moderating duties with Dr. Hagiwara, and I would like to introduce our next speakers, who are Dr. Eugene Yu from University of Toronto, and he'll be discussing unknown primary tumors, where am I hiding?
Good afternoon, and welcome to the lecture on the unknown primary tumor of the head and neck. I have no disclosures. So these are the objectives for this talk. It really is broken into two parts. We'll start off with a simple definition of what is a carcinoma of unknown primary, and then we'll review what truly is a multidisciplinary approach to this entity. We'll end off with some imaging examples of things we may encounter, and throughout I really want to highlight the role that we play as radiologists and where we bring our expertise and value in the treatment of these patients. So if you look at the literature out there, there are actually many definitions of what constitutes a carcinoma of unknown primary, and these vary in little nuances or details. This one here that's listed is a good definition because I think it really matches what the majority of us encounters in practice as radiologists. So a carcinoma of unknown primary is when we have a regional metastatic head and neck carcinoma whose primary site cannot be identified after the initial clinical evaluation. This constitutes approximately 2 to 5% of all head and neck cancers, the majority of which are squamous cell carcinomas. Of these patients that present this way, we find the primary source in up to about half of them. The answer to the question in the title, where am I hiding? The answer in one word is actually the oropharynx, so tonsil and tongue base is by far the most common location. The prevalence of this entity is actually decreasing, but the incidence or the rate of occurrence is actually rising because of the rise of HPV-related oropharyngeal carcinoma. The majority of patients present with a palpable or visible neck mass. About 30 to 50% are located within level 2, followed by level 1 in about 10 to 20%. The classic patient used to be the older male smoker and drinker, but this is actually now shifting to the younger, generally otherwise healthy patient, and again, this reflects the rise in HPV-related head and neck cancer. Some of the things to consider or keep in mind when evaluating these patients: smoking, drinking, sun exposure, any previous history of cancer, including skin lesions that may have been removed, especially from the scalp or face, are important considerations. So for these patients, the goals are to find the primary source, to confirm via pathology, and then to stage it. The finding of the primary site has many benefits. The patients actually like it, so there's a definite psychological benefit for them. It allows for a more focused treatment approach. For example, there's a lot of work being done on de-intensification therapy for HPV-related oropharyngeal cancers. You can give the patient a more accurate prognosis, and once treated, you can have a more focused surveillance program. And the outcomes are actually better in those patients who end up having their primary identified. So again, really significant to find the primary. So what is the diagnostic approach? Well, number one, there is no universally accepted algorithm. What is done, especially in terms of imaging, depends on what you have locally available, the patient resources, access, and wait times. So if we start at the top of this flow diagram, we have the patient presenting with a neck mass. A history and physical are done. The patient is usually scoped in clinic. Most places will do an FNA, ideally under ultrasound guidance, or a core at some places. It is generally accepted that you never do a surgical excisional biopsy unless you are also prepared to do a complete neck dissection at the same time, and this is because of the risk for tumor spillage, seeding. It makes revision and definitive surgery much harder. There's actually an increased risk for local recurrence and distant metastases. The tissue is then sent for histology. Typically, it comes back as squamous cell carcinoma, and you test it for P16 or HPV and EBV. Some places may check for thyroglobulin or calcitonin for a possible thyroid origin if there is upfront clinical suspicion. Some places will test for thyroid transcription factor. This can be helpful as it would distinguish a lung squame in which it'll be positive versus a head and neck origin squamous carcinoma in which it'll be negative. So we're going to get back to this flow diagram in a bit. I really wanted to highlight the importance of viral status. As on the previous slide, HPV and EBV status are often tested for. If EBV is positive, it is very likely that we're dealing with a nasopharyngeal primary. If HPV is positive, then it is very likely that we're dealing with an oropharyngeal primary. So the focus is going to be heavily directed towards the tonsil and tongue base in that example. So what if we have P16 positivity and ultimately it stays as an unknown primary? So where the primary is still not found. So this patient is going to be regarded as having a T0 category and staged as an oropharyngeal primary. So why is this important? And specifically, what do we as radiologists play in this? Well, in the current TNM staging for P16 positive oropharynx, the N class is going to be important as it will dictate the overall stage. And imaging, as we know, plays a huge role in accurately determining the N category. So we have a direct role in patient prognosis in these patients. If their viral tests are negative, these patients are also regarded as T0. And again, the N category and hence the imaging is going to also be important, as we can see what we assess the nodes in terms of sidedness, size, multiplicity, and overt extranodal extension are important in determining the clinical stage. So at this point, there may be some of you listening now and saying, well, officially in the staging manual, extranodal extension or ENE or ECS is determined based on clinical evaluation. However, there is a growing body of work that certain definitions for radiological ENE, especially those with really extremely overt imaging features, is also prognostic, and there is definitely the potential role for the designation of a radiographic or RENE in future editions. So again, it's something to definitely consider. Okay, so back to the flow chart. So once there is tissue confirmation, the next step is to assess with imaging. And one point is that imaging should be done, that I want to emphasize is that imaging should be done prior to any operative endoscopy or biopsy, as inflammation or distortion from such procedures may affect the imaging interpretation. So most places, in terms of imaging, start with conventional cross-sectional modalities, CT and MRI. They're cheaper, they're more available. And the literature shows that these two are pretty much equal in this patient population. You will find a primary in about 30% of patients at this point. If conventional imaging does not find anything, the next step, as you can see on the chart, is PET scan. And there are several studies on CT and MRI versus PET scan in patients with an unknown primary. And this is one of them published in Radiology. The bottom line is that PET CT outperforms CT and MRI in these patients. A couple of other papers. The first is a meta-analysis on PET CT in finding the primary site. They showed a detection rate of about 44%. So PET will detect the primary site in about 30% of those missed by conventional imaging. And it also picks up distant metastases in about 11% of cases. The other paper shows that even if the PET CT is positive, you still should proceed to the next step, which is operative endoscopy to confirm. The actual highest detection rates in the literature is actually this combination of PET CT followed by a PET endo. So what happens if imaging is all negative? So, well, we can still play a role as radiologists, and again, it goes back to what we say and interpret about the nodes. When we assess the nodes, keep in mind the location, as this may be a clue to the location of the primary. For example, higher nodes in level 1 or level 2, these suggest a more likely source in the oropharynx or nasopharynx. If you have nodes located only in the lower neck, this should raise the possibility or the likelihood of a non-head and neck source. So you should pay attention to those sites on imaging, or at least raise the possibility to the clinician who can assess accordingly. For example, they can do a bronchoscopy to look for a lung lesion. Other things to consider when we assess nodes, if bilateral, again, think nasopharynx and base of tongue. They like to go bilateral. Parotid nodes, think about the skin and scalp. If you note diffuse adenopathy, this actually corresponds to a higher rate or higher risk for distant metastases. So it may warrant consideration for a PET CT scan, even if the primary is actually found. So again, assuming that after all of the investigations, the primary site is still not histologically confirmed, what about treatment? There still is some variability in the approach because there are no randomized prospective clinical trials on this entity in terms of treatment. There are a lot of things to consider, among them patient status, viral status, as these will influence what the patient can tolerate, as well as possible prognosis and de-intensification protocols, for example, in HPV positive disease. Options for the primary site or suspected primary site in terms of treatment, one is performing tonsillectomies, potentially by robotic or laser approach. Primary radiation, if that is the route, will be influenced by viral status and nodal location. Again, some sites of nodal disease may be suggestive or have an influence. So, for example, the presence of level 3 nodes may prompt expansion of the radiation field to include the larynx. Otherwise, it may not have been included in some institutions. In terms of treating the neck, again, many options. So surgery, radiation alone, multimodal chemorads. Again, this important decision is going to be influenced by nodal status. And again, I want to emphasize imaging plays a role along with viral status in this determination. For example, a patient with a smaller ipsilateral node and which is HPV positive, radiation alone may be an option. If we as radiologists call overt radiographic extranodal extension, for example, we see nodal disease encasing the carotid, going to muscle, into the skin, that's probably chemorad's territory. Again, that's a radiographic finding that we contribute. So we have to be sure we assess and report all of these potential imaging features. Okay, so let's look at some imaging. So given that patients typically present with a neck mass, nodal imaging is something we're going to encounter, and as you probably have noticed, I've been trying to emphasize the role that imaging plays in this aspect. So here's an example. This is a 49-year-old male presented to ENT with a neck mass. The referring MD did not see a primary. right away we see that there is right level 2 cystic nodes, and we can actually see a right tonsillar mass. So this is an example of a P16 positive tonsillar carcinoma. As a radiologist, our role assess the nodes, the size, the laterality. We see that they are high in the neck and cystic. So based on that alone, we should be thinking likely HPV-related cancer in the oropharynx. There's nothing too crazy in terms of the nodal appearance in this case. And with this, the clinician will have a great idea of where to look to confirm the primary, give the patient an accurate prognosis, and be able to develop a treatment plan. Here's another patient with a neck mass, but this is very different in terms of the nodal disease itself. And again, remember, this is how we bring value to the process. The nodal disease in this case is very large. The margins are overtly ill-defined. There's involvement of the sternocleidomastoid muscle, the platysma, the nodal disease in cases necrotic. So this is overt extranodal or overt radiographic extranodal extension in this example. This is another example. It's a 57-year-old male, aggressive-looking, coalescent right nodal mass invading the musculature again, ill-defined margins. Again, imaging is very suggestive for radiographic extranodal extension. And like the other one, this nodal appearance in our radiographic interpretation will help influence the treatment approach. So even if all imaging is negative in terms of finding a primary site, there's still importance from what we see and document. And again, this has to do with the nodes. This is an example of a treatment approach. And as you can see, all of these nodal categories, N2A or B or N3, that we help determine on the scan will in turn guide the treatment. So size, multiplicity, bilateral, contralateral status of nodes that we document may influence if a patient, for example, gets primary radiation or plus or minus chemo. And as we just saw in those examples before, overt radiographic extranodal extension can also shape whether or not the patient gets chemotherapy, for example. How about this example? Again, this is meant to highlight that the appearance of the node is important. So we already talked about cystic nodes as a clue for HPV, but how about these cystic nodes? So this recently came to one of my head and neck surgery colleagues about a month ago in June. So this is a 32-year-old female that was referred to him as an unknown primary. The first MD actually did the CT scan to assess. So you can see the arrows pointing to the cystic nodes in the neck. The outside radiologist made this interpretation to complex cystic masses, aka nodes, that we saw on the prior slide. And the radiologist was thinking mucosa, and actually made a call on something in the molecula, you can see, and identified and actually measured and gave measurements for what they thought was the potential primary lesion. But the clue to the real diagnosis is actually there on those images. So don't forget to look at, to really look at the appearance of the node. So in this case, we have cystic nodes, which, yes, can be a clue for HPV disease, but it is also odd to see those nodular foci enhancement. Okay, the location too, these nodes were isolated to the lower neck with nothing up top, which would not be great for HPV oropharynx. The patient demographics, this was a younger female patient, is also a clue, as we shall see. And another finding that they actually mentioned on the report, you can see highlighted in the blue, incidental thyroid nodule. So when I was asked to reread the CT scan, this to me was metastatic thyroid carcinoma until proven otherwise. And that's exactly what this turned out to be when our surgeon actually did the FNA on the nodes and actually did the FNA on the thyroid nodule. So don't forget to really look at the node. In this case, these nodes are classic metastatic thyroid carcinoma nodes. Another feature on the prior example that I again wanted to emphasize and think about the location of the nodes. So low neck adenopathy without anything really higher up. Again, probably not great for an oropharyngeal carcinoma. So think elsewhere, for example, thyroid, like in that prior case, or larynx, or something from below the clavicles. In this example, we see a lower neck nodal mass. And this was a lower esophageal carcinoma primary. Another important feature to note that we can see on this case, the left carotid encasement. When you see this, this makes it unresectable. And again, this is obviously important as it would influence the patient's prognosis and treatment available treatments. This is actually the PET scan for that patient on the previous slide. The PET actually found the primary, as you can see here, highlighted right there. And the PET scan is really indeed helpful in this case. For example, this is the corresponding regular CT scan. Again, it's really hard to see the primary in the esophagus on this CT scan. All right, how about the primary site? That's one of the main goals in this patient population, to find the primary tumor origin. As we saw earlier, sometimes it's easy, like this example. Statistically, we know right away that the majority of the patients will end up having an oropharyngeal primary tumor. In this case, we see a large base of tongue mass on the MRI. On the PET, we can see that it's really easy to see as well. So definitely not an eye test on this example. So conventional imaging can definitely help find a primary, but if not, like for example in this patient with a left neck mass, the MRI images are looking pretty clear. We move on to the PET scan. And in this case, the PET scan showed a lesion in the left nasopharynx. It was deep and submucosal. And this actually turned out to be a path-proven nasopharyngeal carcinoma. And even in retrospect, I think looking at the MRI, it's really not visible. So again, PET imaging can definitely be of value. What are the reasons why imaging would not show the primary? Well, number one, the quality of the scan is a factor, especially in motion, especially in MRI. Waldeyer's ring, these tissues will normally take up FDG, which can confound or obscure a primary tumor. The primary can be really small or superficial, which makes it hard to see or detect it on imaging, or the primary is located or situated in a site that the radiologist may not be as familiar with looking at. For example, the hypopharynx. Not too many radiologists have a lot of experience looking at this site, so it could be a hidden site, if you will. This patient was referred to our place as an unknown primary. Our surgeon, when they examined, actually noticed a superficial ulcer in the left vallecula. Looking at the MRI, a little bit of motion. There may be a hint of something there, but it's a bit of a stretch. The PET scan also did not really see much. So this is an example of a small and superficial lesion that can be really hard to see on any of the types of imaging that we normally do. This is a male patient, again, bilateral cystic nodes high up in the neck. So again, thinking right away, likely HPV oropharynx, and the CT, again, not much to see in terms of the primary. So as we saw on that flow diagram, the next step, PET scan, which shows the lesion nicely in the right colossal tonsillar sulcus. And again, even in retrospect, it's really hard to make the call, I think, on the regular CT. So small, superficial again, but in this case, the PET scan was able to actually pick it out. This is an example of motion hampering visualization. This is a male patient with right neck nodes. The MRI, again, not great, a lot of motion, but the PET scan was able to find the primary in the right arepiglotic fold. The palatine tonsils we know is a common likely source for a primary, but again, Waldeyer's ring can make it tough, especially on CT and even MRI, because the tissues would already have volume in that location. For example, this patient was eventually found to have a lingual tonsillar primary, which is very hard to pick up on the MRI. But the PET scan, as we can see here, picked it up because in this case, the SUV of the primary tumor was sufficiently higher than the native uptake from the lingual tonsillar tissues to make it stand out. Another example, hard to make the call on CT and MRI. but the PET scan shows the mass hidden amongst the lingual tonsils. Again, because the SUV was sufficiently high, it would actually show up on the scan. How about false positives? We again have to keep in mind false positives, especially on PET. With PET, we must be very careful with the timing of the scan. This one shows a region of high uptake in the left tonsil. But when we looked at the patient's notes, this patient actually had a tonsillectomy done about a week prior. So again, this makes it really hard to interpret, the PET scan now. This patient has a cystic node in the left neck, and the outside clinician actually did an excisional biopsy, which, as we now know, is not a good idea. The PET scan was done shortly after, and it shows uptake. So now the PET's finding is really confounded. Is this a false positive because of the surgery, or is there actual residual tumor that still needs to be treated? So again, really, the timing is really important. Always want to do the imaging before any type of operative treatment or endoscopy. Another benefit of PET-CT is shown here. This is a 63-year-old female that ended up having a right base of tongue tumor that was negative on all imaging, but the PET scan actually showed a secondary lung adenocarcinoma. So again, can definitely have benefits. This is another example. This patient presented as an unknown primary tumor in the neck. The neck disease ended up being a soft tissue sarcoma. And the PET scan that was done actually found a primary in the right breast, as you can see here on the scan. Another benefit of PET-CT is that it can pick up distant metastases. This is a pretty neat case. So this patient, unknown primary carcinoma, and we see a metastasis in the left adrenal. And the brain was also odd too. So that, again, the brain normally takes up a lot of FDG. It's really metabolically active. In this case, it was actually a photopenic void that was picked up on the PET, as you can see here. And this prompted an MRI, and this was actually an asymptomatic cerebellar metastasis. So again, this is a really significant and impactful finding that the PET contributed to. This is my second last slide. So 65-year-old female, isolated low neck node, and actually it's actually pretty small. So it's actually pretty impressive that the patient or the clinician who picked it up. So again, we have an isolated low neck node. So knowing this should at least prompt the thought of a non-head and neck primary. And the PET scan indeed showed or picked up the lung primary and multiple bone metastases. So again, remember that the PET-CT picks up distant mets in about 11% of these patients. So with that, I will end. So we've reviewed the truly multidisciplinary approach to patients with an unknown primary neck carcinoma, and I really hope that I was able to highlight to you the important role that imaging plays. What we see and report on can have a direct effect on patient prognosis and also mold and guide their treatment approach. Thank you very much.
And next, to wrap up this outstanding session, is going to be Dr. Tong from Loma Linda, who will be discussing extranodal lymphoma, differentiating features from other malignancies. And on behalf of Dr. Hagiwara and myself, I'd like to thank you for attending this session. We can be answering questions and discussion within the chat window linked to this session. Thank you very much. And again, thank you to our program committee for this excellent virtual program.
Hi, this is Dr. Karen Tong from Loma Linda University Health, California. I'll be giving the next lecture on extranodal lymphoma differentiating features. This first slide lists some excellent papers that I recommend for your reading pleasure that pertain to this topic. The first is an article by Drs. Aiken and Glastonbury from 2008, Imaging Hodgkin and Non-Hodgkin Lymphoma in the Head and Neck. Another excellent paper from 2011 by Thomas et al. In AJR, Extranodal Lymphoma from Head to Toe, Part 1, the Head and Spine. And a more recent review by the esteemed Dr. Wendy Smoker's group, Multimodality Imaging Spectrum of the Extranodal Lymphomas in the Head and Neck, a pictorial review. A couple of points about classification. In 2018, AJCC published their 8th edition with updates in head and neck cancer staging. In 2017, WHO published their 4th edition of classification of head and neck tumors, as well as classification of tumors of the hematopoietic and lymphoid tissues. One point to remember is Waldeyer's ring is technically extranodal, but is considered nodal for staging purposes. There may be some differences in a reporting of parotid lymphomas due to variation of classification. Although parotid is considered extranodal, being outside of a lymphoid organ, some lymphomas actually represent nodal lymphoma arising from nodes in the parotid gland. So let's briefly review lymphoma. It is the second most common neoplasm in the head and neck after squamous cell carcinoma, although some authors report thyroid carcinoma as number 2 and therefore lymphoma as number 3. It is the most common non-epithelial malignancy of the head and neck. It affects all ages but usually presents later in life, but it is the most common diagnosis for a unilateral neck mass in the young adult. It's a wide range of presentations, overlaps with infection, inflammation, and other malignancies. It is known as the great imitator, so should be considered in any differential of a mass lesion in the neck. And it's usually diagnosed by widespread lymphadenopathy. The location varies in the literature and depends on the subtypes. So here's a list of the major subtypes: the B cell, T cell, the natural killer or NK cell, and the Hodgkin or Reed-Sternberg cell. There are 2 main presentations: primary lymphoma, which is confined to a subsite without additional sites, or secondary, which is a focal lesion in the presence of disease in neighboring areas or systemic involvement. There are 2 main groups, the Hodgkin's and the non-Hodgkin's lymphoma. In Aiken and Glastonbury's paper, they have a nice table that classifies the imaging patterns of head and neck lymphoma on cross-sectional imaging. It's a modification of previous work by Lee et al. So type 1 is nodal, type 2 is extranodal, type 3 is combined nodal and extranodal, and type 4 is multifocal extranodal. This slide briefly summarizes the differences between Hodgkin's and non-Hodgkin's lymphoma. So in age, Hodgkin's is more commonly in the younger population, median age of 28, but there is a bimodal distribution of young and elderly, whereas in general, non-Hodgkin's lymphoma predominantly involves the elderly with a mean age of 67. Hodgkin's is usually nodal with contiguous spread, whereas non-Hodgkin's lymphoma is usually non-contiguous adenopathy. The favorite nodal involvement of Hodgkin's is the anterior jugular and the mediastinal nodes, whereas in non-Hodgkin's lymphoma, it tends to go to the other cervical chains and as well as the abdominal nodes more often than the mediastinal nodes. So, not surprisingly, in Hodgkin's lymphoma, it's usually the type 1 nodal imaging pattern. Extranodal disease is not common, less than 4 to 5% of cases, whereas extranodal disease is more frequent in non-Hodgkin's lymphoma. The number 1 site is the GI tract, whereas the number 2 site is the head and neck. There are 4 histologic subtypes of Hodgkin's lymphoma that are listed here. There are over 20 different types of non-Hodgkin's lymphoma, so there's various manifestations and subtypes. There are also risk factors that may be associated, including immunodeficiency, HIV, Hashimoto's, Sjogren's, Maculate's, and EBV infection. Higher grades are often necrotic. So extranodal head and neck lymphoma has been abbreviated either EHNL or ELHN, depending on the literature. It is rare. It's usually of non-Hodgkin type. It may be the first presentation of non-Hodgkin's lymphoma. It can occur with widespread nodal disease or without widespread nodal disease. The most common locations will be Waldeyer's ring in more than 50% of cases, and also commonly involves the paranasal sinuses and the nasal cavity, and less commonly some other parts of the head and neck. So this table by Thomas et al. Shows the breakdown of frequencies of the common, more common lymphomas of the head and neck. So most common are actually the diffuse large B-cell and the follicular lymphoma with the highest frequency. And some of these other B-cell origin lymphomas also occur, like the MALT mantle cell Burkitt. Much less common will be the peripheral T-cell. Most of these will occur in the older population, except in Burkitt's, which is more common in children or adults who are immunocompromised. And these are some of the clinical features listed on the right. This just pretty much summarizes the frequency of those lymphomas. So the common ones, as I mentioned, are the diffuse large B-cell and the follicular. Less common will be MALT, Burkitt, and peripheral T-cell. You can also divide these by tumor behavior. The more aggressive ones will be the diffuse large B-cell, Burkitt's, T NK cell, lymphoblastic, and the lymphoma associated with HIV. The more indolent ones are the follicular, low-grade B-cell, MALT, and plasmacytoma. This is a table from the pathology literature. I'll just go to the next slide to show you the reference. And the references will be listed more fully at the end of this slide presentation. But this list has a greater breakdown of more of the head and neck lymphomas. And they go into greater detail regarding, of course, the pathology differences as well as genetic and some treatment and prognosis differentiating features for your interest. There's a couple of other papers that I recommend also will be listed at the end of this slide presentation. So again, Picard et al. Broke down the frequency of some of the more commonly seen head and neck lymphomas. Again, most of these will be B-cell type, and see these are some of the subtypes that we've mentioned. T-cell is much less common, plasmacytoma also very uncommon. Stork et al. Also did a pie chart, which nicely shows the distribution of frequencies. Again, diffuse large B-cell tends to be the most common, follicular is close, Hodgkin's lymphoma is also fairly frequent, and these rest are much less frequent. Drs. Aiken and Glastonbury have a nice table that is more relevant for us as imagers. These are some of the more commonly encountered non-Hodgkin's lymphoma in the head and neck that we will see, and list some of their common locations and the features that we may come across. So we may see MALT, which is more commonly involving the orbits, parotid, and thyroid glands. Follicular and B-cell tend to involve Waldeyer's ring, most commonly. NK T-cell likes the sinonasal region, Burkitt's likes the mandible and maxilla, and these are some of the things that we may encounter. So let's very briefly go through each of the cell types that we may run across, and then later we'll look at the locations. So first of all, the diffuse large B-cell lymphoma, and this is an aggressive high-grade disease. It is can be nodal and extranodal. If so, the disease stage is upgraded. If it's only extranodal, it has a predilection for the thyroid and some of these other tissues. Overall, though, the most common head and neck site is Waldeyer's ring, and it's also common in the paranasal sinuses and the jaw. So the next one that we may encounter is the MALT lymphoma, the mucosa-associated lymphoid tissue. It is a type of marginal zone lymphoma that arises from B cells. So there are three kinds of marginal zone lymphoma, the MALT, as well as nodal and splenic. Of course, we're not going to talk about this. The MALT is most common in the stomach, but we, of course, can encounter it in the head and neck, in which case it may occur in the orbit, salivary glands, larynx, and thyroid. It's indolent, rarely progresses to diffuse large B-cell. What's interesting about it is it's thought to be an antigen-driven neoplasm, so it's often associated with autoimmune disorders and chronic infection inflammation. So in the parotid, it may be associated with Sjogren, IgG4, maculitis. In the thyroid, it may be associated with underlying Hashimoto's. And in the orbit, it's thought to be associated with chlamydia psittaci infection. So let's look at Burkitt lymphoma. It rarely involves the extranodal head and neck. It tends to be high grade, highly aggressive, but it's also highly chemosensitive and curable, and it is associated with EBV. It has a predilection for the mandible and maxilla. There are three main types: the endemic, which is more frequent in Africa, usually in the pediatric population, males, and involving the jaw and facial bones. Also, you can see this with immunodeficiency associated, or HIV, and sporadic, which tends to more frequently involve the abdominal organs. The other one that we may encounter is the NK T-cell lymphoma, particularly the nasal type. It was once known as one of the causes of lethal midline granuloma, although there are other pathologies grouped in this name, so it's not used as much. It is an aggressive neoplasm. It has marked destructive capabilities, particularly osseous, but also vascular and with prominent necrosis. It frequently progresses to disseminated disease and has a poor prognosis. It too can be associated with EBV. It's more common in males, particularly Asians, and in Central South America. So it's actually fairly rare in European populations. Also, follicular lymphoma, it is equally prevalent or almost equally prevalent to the diffuse large B cell. It tends to be more indolent than diffuse large B cell, and extranodal disease is more rare. The peripheral T cell, we may also encounter it, although it is relatively rare. It has a predilection for skin, like mycosis fungoides. And plasmacytoma of the head and neck, also rare. It tends to be indolent, more common in the males, but we may see it in the nasal or oropharynx, larynx, or temporal bone. So let's move to imaging strategies and look at some examples and cases based on location. So imaging cannot reliably distinguish head and neck, Hodgkin's lymphoma and non-Hodgkin's lymphoma lymphadenopathy, although, as we've heard, there are some things that may help us, or from other malignancies. Oftentimes we'll encounter these cases initially by ultrasound referral for biopsy or detected on CT. CT is useful for detecting bone destruction, particularly the more aggressive ones like Burkitt's, diffuse large B cell, and the NKT cell. It's not very good for distinguishing post-treatment fibrosis from residual active tumor, which will be better distinguished by PET. When it comes to then staging, whole body evaluation is important. So this is where we may be doing contrast CT of the neck and the torso, and PET imaging, which is very helpful for high-grade tumors, which show avid uptake, but not so sensitive for low-grade lymphomas, particularly the peripheral T cell, marginal zone B cell, and the grade 1 cutaneous follicular ones. It is superior to CT for showing external disease, detecting residual active tumors, so it's useful for staging, measuring treatment response, surveillance, and restaging. MRI is useful for detecting extension into other fascial spaces or invasion of the intracranial or interspinal regions. And of course, DWI may be helpful. So here are some typical imaging features of extranodal head and neck lymphoma. Often we'll have presence of homogeneous density or signal, tends to be intermediate to low signal on fluid-sensitive MR, tends to have diffusion restriction, tends to have vascular encasement without compression, and moderate to intense enhancement. Usually there's an absence of calcification or necrosis unless it's a post-treatment case. Also tends to have absence of hemorrhage and cystic changes, as well as bone destruction unless it's the aggressive type, an aggressive type. So let's look at locations now. So Picard, in their paper, has a nice breakdown not only of age distribution but also location. As we mentioned before, these types of lymphoma tend to occur in the older population. The locations of all types of extranodal head and neck lymphoma are shown in this pie chart. So palatine tonsils tend to be most frequent, and as you can see in descending order, other things include the nasal fossa sinus, nasopharynx, parotid, orbit, thyroid, temporal bone, larynx. one thing to remember in trying to differentiate our most common pathology that could be a differentiating problem is squamous cell carcinoma versus lymphoma. So squamous cell carcinoma of the head and neck is much more common than lymphoma of the head and neck, but both can present with nodal and extranodal disease. But just remember, squamous cell carcinoma does tend to have necrotic nodes, tends to have the absence of distance disease, and is more likely to have skull base erosion. But again, it is not a perfect differentiation. So now let's go through some sites. And I have started with this rather large encompassing area of oral pharyngeal laryngeal region because Waldeyer's ring is in fact the most common. But I've listed a couple of other things that are sort of in this category. So as we mentioned before, Waldeyer's ring is the most common extranodal head and neck lymphoma site. More than 50% of cases. They're usually B-cell and usually intermediate grade. So palatine tonsils are most common. Number 2 is adenoids. Number 3 is lingual tonsils. So we also mentioned that the mandible and maxilla is often involved. Again, Burkitt's lymphoma is more common. Non-Hodgkin's lymphoma is actually rare, but can involve the mandibular canal or mental foramen. But the differentials you might want to keep in mind are going to be the Ewing's, the Langerhans cell histiocytosis, leukemia, osteosarcoma, and Mets. Oral cavity is uncommon, but it can be seen in AIDS. And larynx is very rare, but it may be more often due to MALT, and it's usually supraglottic with spread to the pharynx. Again, the differential diagnosis is squamous cell carcinoma. So let's look at some cases. This is a diffuse large B-cell lymphoma involving the palatine tonsils and the nodes. So you can see the involvement of the palatine tonsils. Also, a very avid uptake on PET. And on the axis, you can see there's even a necrotic node because this is a high-grade tumor. Again, increased activity on the PET. So let's look next at the sinonasal region. It is relatively rare. It is 1 to 15% of sinonasal malignancies are from lymphoma. And in general, it is less than 1% of all extranodal sites. If it is involved, it tends to arise more in the nasal cavity and then the sinuses, in descending order being maxillary, ethmoid, sphenoid, or frontal sinuses. There are 2 main subgroups of sinonasal lymphoma. There's the diffuse large B-cell and then NK T-cell. So diffuse large B-cell is actually more common. It has actually slightly better prognosis, usually men, whereas the NK T-cell is more common in, as we said, Asia and South America, associated with EBV, often destructive with nasal septal perforation and involves the nasal cavities more than the sinuses. These tend to be heterogeneous on T2, moderately intense enhancement, and again, the differential diagnosis includes various sinonasal masses, including fungal infection, Wegener, squamous cell, esthesioneuroblastoma. But remember, squamous cell is the most common malignancy, and it's more likely to rise in the sinuses. So let's look at some cases. This is a high-grade diffuse large B-cell lymphoma of the left maxillary sinus. And you can see the bone destruction because it is high-grade. This patient actually came back 2 months later with further spread into the right maxillary and frontal sinus as well as into the orbit. Again, a lot of bone destruction from this high-grade tumor. This is his MRI that shows the enhancement of the tumor. Notice that on a non-contrast T1, it's hard to differentiate the tumor from just mucosal inflammation or fluid. This is where the enhanced scan or even the T2 weighted image can help differentiate because the tumor will tend to be iso to hypointense, whereas the mucosal inflammation will be very bright. And again, increased markedly avid uptake on PET. And again, the same patient, again, showing the differentiation between the tumor and the mucosal inflammation or fluid, and the diffusion restriction that is not uncommon in these lymphomas, helping to delineate this as well. And this one actually also had elevated perfusion. So let's look at salivary locations. So salivary can be divided into primary or secondary. Primary is rare. It's more common in the parotid gland. Again, it can be associated with chronic inflammation. Some of these risk factors we mentioned before. There's actually a 40 times risk with Sjogren's. Criteria for primary is involvement of the gland and not the node, and that the lymphoid infiltrate of the gland is malignant. These are the most common subtypes that involve the salivary gland with primary lymphoma. So MALT, follicular, and diffuse large B-cell. MALT may have cystic foci, but because it's indolent and low-grade, it doesn't tend to be FDG avid, whereas diffuse large B-cell is avid on FDG PET. Secondary lymphoma is more frequent than primary. It can present as a solitary mass or unilateral, bilateral, or diffuse glandular enlargement. Again, the differential is of various salivary lesions, including the primary salivary tumors, Warthin's, Mets, to the nodes in the parotid gland. But remember, salivary gland malignancies are more common in the submandibular and sublingual glands, whereas primary lymphoma or secondary lymphoma is more common in the parotid. And these other lesions tend to have a higher diffusion than lymphoma. So let's look at a case. This is a follicular lymphoma of the bilateral parotids and nodes. There's a discrete lesion in the left parotid on these axial and coronal CTs, and later he actually presented with involvement of the right parotid and also some adenopathy in the neck. This is a different patient with MALT lymphoma, and this is his lesion in the right parotid. Notice the post-contrast is actually harder to delineate because it blends in with the gland. It's actually easier to distinguish on the non-contrast T1 or the T2 weighted imaging. So you can see the distinction between the more normal gland and the tumor. And notice it does have some small cystic components, which is not uncommon in MALT lymphoma. This is just coronal images of the same patient, again showing the differentiation nicely seen on the more T2 weighted image and the small cystic components. Let's look at the orbit. So lymphoma is the most common orbital malignancy in adults older than 50 to 60 years. It accounts for 30% of all orbit tumors. It can be part of a widespread disease, and it's usually low grade. If it's primary, it's usually of MALT histology, but can be follicular, mantle cell, or diffuse large B-cell or lymphoplasmacytic. Again, there is some thought that it may be associated with infection. Some groups will include an adjuvant doxycycline antibiotic therapy, although that is still controversial. There is a predilection for the lacrimal gland, but can also involve the muscles, the retrobulbar fats, the conjunctiva, and the eyelids. Remember, the differential includes other orbit diseases like thyroid orbitopathy, pseudotumor, IgG4, and sarcoid. Lymphoproliferative disease in the orbit can range anywhere from just benign hyperplasia to the malignant lymphomas, and it honestly can be difficult to differentiate for us, as well as actually the pathologist sometimes. And bone destruction is rare unless it's a high-grade lymphoma. So this is a nice frequency distribution by Gorbino et al. That shows the more common locations in the orbit. Again, superlateral, based on particularly the superior rectus and the lacrimal glands. It's usually intraconal, and again, most commonly superior rectus, but some of these other structures as well. So let's look at some cases. Here's a MALT lymphoma of the lacrimal glands, bilateral disease, no bone destruction. This is the MRI that shows, again, the very typical superlateral quadrant involvement. This is a different case given to me by Dr. Eugene Yu that nicely shows the diffusion restriction in these bilateral lacrimal associated lymphomas. This is another case that shows involvement of the medial rectus on the axial and the coronal views. Again, this is not the favorite location being the superior and the lateral, but just remember that it doesn't have to follow those rules. So this was a diffuse large B-cell lymphoma of the medial rectus. This is another case of follicular lymphoma, which involved the optic nerve sheath as well as some rectus muscles. Another case given to me by Dr. Sepadari showing an intraconal diffuse mass that encases the optic nerve sheath. A similar case by Dr. Eugene Yu, again, intraconal encasing the optic nerve sheath. And this case that showed a similar lesion as well as an additional lesion that helped support that this was a multifocal process. This is also a nice case from Dr. Eugene Yu showing the scleral involvement and the retrobulbar involvement of this lymphoma, orbital lymphoma. So let's move to thyroid. So thyroid, it's a primary lymphoma is uncommon. It's often in elderly females. It's a rapidly enlarging thyroid mass is a common presentation. It's often associated with underlying inflammation like Hashimoto's in up to 80% of cases. Most common types are going to be the diffuse large B-cell and the MALT. There are 3 presentations, either solitary, multiple, or diffuse glandular enlargement, and the differential will be carcinoma, particularly anaplastic, or goiter. So here are a couple cases. Here's a diffuse large B-cell lymphoma of the thyroid, this very large, heterogeneous and enlarged thyroid gland, almost looks like a goiter. Notice the avid uptake on PET. Here's another case that is a lymphoma in a young male. I don't have the histology subtype, but obviously causing displacement of the trachea, and he presented with airway compromise. Last, getting near the end, this is less common, skull base and temporal bone, more likely to be part of disseminated disease, can involve various parts of the skull base, most frequently diffuse large B-cell and Burkitt, can be associated with perineural tumor spread, so must remember to look for that. Some of the differentials of skull-base tumors are listed here, can involve clivus, cavernous sinus, and T-bone. So let's look at a case of a T-bone and EAC, diffuse large B-cell lymphoma. This patient presented with hearing loss. You can see the soft tissue in the EAC and some opacification of the air cells that are not specific. PET shows avid uptake in this region as well as in the left nasopharynx. And on MR imaging, you can see the non-contrast T1, not very helpful, but contrast shows the delineation between the tumor, enhancing tumor, and the pacified air cells. And T2-weighted imaging is also very helpful in distinguishing the macero diffusion from the tumor, invading both temporal bone and EAC. Other uncommon sites, very briefly, carotid space and muscle. Here's an example of a mycosis fungoides involving the periauricular soft tissues. Went to radiation therapy, but unfortunately recurred. There are a couple of other unusual types of head and neck lymphomas in the immunocompromised population, so whether PTLD or AIDS related. In the interest of time, I'm not going to go through these. These are much less common, but you can review these at your leisure. So in summary, Hodgkin's lymphoma is predominantly nodal and involves contiguous spread. Non-Hodgkin's is frequently extranodal, especially Waldeyer's ring. There are aggressive types like NK cell and Burkitt's. They're often associated with bone destruction. The low-grade types like MALT and B cell are usually well circumscribed and homogeneous. They tend to lack bone destruction. Diffuse large B-cell likes Waldeyer's ring and paranasal sinuses. MALT likes the orbit, salivary glands, and thyroid. Remember, Sjogren's is associated with MALT of the parotid. Hashimoto's is associated with MALT of the thyroid. NK cell likes nasal cavity. Burkitt's likes maxilla and mandible. And HIV is associated with diffuse large B-cell of the oral cavity. Here are some additional references that I alluded to earlier. So if you would like to review any of these other papers that I used some of their tables and graphs. And I do thank you for your attention.